Hello? Hello?
And expertise. Can you? Oh, okay. There was a issue with the noise, with the sound. Can you? Okay. Can everybody hear? You can write in the chat. Okay. Thank you. Thank you. So I will take it from the beginning. Sorry. So for those who haven't joined and those who are not going to hear me, we are extremely honored to have with us Professor David HEYMANN on a MediPIET webinar on current evidence on COVID-19 epidemiology. The professor is currently Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine and Head of the Centre on Global Health Security in Chatham House at London, UK. All of you know him. He's a professor. His experience and expertise is extraordinary. We are very privileged to have him as our invited speaker in this second webinar of the MediPIET family. And of course, probably all the participants in this call have studied and always use as a reference his Professor HEYMANN's book on Control of Communicable Diseases Manual, which all public health professionals have it in our library. So I would like to express our gratitude in advance to for accepting to share his insights and his long-term expertise experience in communicable diseases, and specifically now with this global pandemic that we are facing. So the aim of today's webinar is for professors to join to share with us the current evidence on COVID-19 epidemiology, including clinical patient severity and mortality, some findings of the risk factors for the disease severity, and we will be delighted to hear his views on the evolution of the COVID-19 epidemiology now around the globe, and in a specific context, as Professor Mondressing, thank you. Some of the countries that are in the MediPIET network, but also countries that are connected with us in this webinar, are some of them are like now maybe in the peak, some of them in the beginning, and some of us are at the end of the epidemic curve, at least of this phase, this wave of the epidemic curve. So we would like to would like your views and your insights on the interpretation of this epidemiological evolution. So having said that, just to remind everybody that for GDPR issues, or for those of you who want to directly address a question to the professor, you can, after his talk, after his 30-minute talk, there's going to be a 50-minute question and answer section. Please use the raise hand feature on the WebEx, and then we will give you the floor and you can address the question to the professor. And otherwise, type in the chat box your question, and then the moderator will address the question to the professor. So because the webinar is recorded, and the recorded version is going to be uploaded on the MediPIET website. So having said this, I would like to give the floor and thank again Professor HEYMANN for the honor that he did, for the honor that we have to have him here, and we just give the floor so we open the webinar.
Thank you very much. Are you hearing me?
Yes, Professor. Thank you.
Okay, thanks very much. I'm really pleased to be able to speak with you today, and I have put together a slideshow which I'm going to try to share with you now, and hopefully get it up on the screen. Okay, are you seeing the slides on the screen? Okay, very good.
Yes.
So what I will talk about is the new coronavirus 2, SARS coronavirus 2, and I'll try to tell you what we know, what we don't know, and what we need to know in order to deal better with the pandemic. So I will start, and if you're not understanding me, I'm happy if you interrupt at some point and just let me know, and we can go back over anything that hasn't been clear. But I'll start with the first slide. If I can, let's see, how do I need to, okay. On this first slide, I'm going to talk about coronavirus infections in humans. I believe you know that there are 4 endemic coronaviruses that are always in human populations. These coronaviruses cause symptoms similar to the common cold. In fact, they're a cause of the common cold. And they spread throughout countries, and they occur mainly in the winter months. They cause illness in the winter months when people are more indoors and closer together. Then, in addition, there are 3 new coronaviruses that have come into human populations since 2003. And that includes the SARS coronavirus, the MERS coronavirus, and the SARS coronavirus 2, which is the virus that's causing the pandemic now. Each one of these viruses has had a different destiny. So we really don't understand enough to know why, but the SARS coronavirus came into human populations. There were containment activities throughout the world, and the virus disappeared. It was a one-time mutation thought to have infected humans in Guangdong province in China from a live animal market in November of 2003. It circulated in human populations for a period of 6 months. Containment activities were done by every country, and it was able to, transmission was interrupted, and the virus disappeared. The second coronavirus is MERS coronavirus, and that emerged in about 2015, and that maybe even earlier, I'm not sure of the exact date, maybe 2012, but whenever it emerged, it's a virus which has continued to emerge periodically in humans. This virus is carried in the nasal passage of camels in the Middle East and in Africa, and occasionally it infects humans. But humans don't transmit this from one to another unless there's transmission in a hospital setting where there's nosocomial transmission. And the biggest nosocomial outbreak of this coronavirus, the MERS coronavirus, was in South Korea, where there were over 200 people infected through poor infection prevention and control measures in hospitals throughout the Seoul in Korea. The current SARS coronavirus, SARS coronavirus 2, is a virus which we don't know its final destiny. It's transmitting very easily from person to person, and we just don't know what the final destiny will be. Will it become endemic, like HIV did after it emerged? Or will it come and then disappear, as did SARS coronavirus? Or will it not, will it continue to circulate for a time and then become endemic in some animal and then cause a threat to humans? It's just not known what the final fate of this virus might be. Shall I stop there and ask if people are understanding and if there are any questions? It's clear?
Yes, Professor, there are no questions. Everything is clear.
Okay, so I will continue now, but maybe we could have people go on mute to be sure that we're not disturbing each other.
Yes, all of our participants are mute, but there are people joining. So
okay, that's what I'm hearing. Okay, no problem. Okay, so now, what do we know about this SARS coronavirus 2? Well, we know a lot because there's been a lot of technical information that's been shared around the world, and Spain has actually shared much information. Bruce Edward from WHO was there and brought back a lot of information to WHO, and we've been reviewing that information with information from China and countries around the world in the WHO Technical Advisory Group that I chair. And so we know that this infection is transmitted through droplets that spread from human to human, from a cough, or even from speaking. And we know that about approximately 2-meter distance will prevent those droplets from infecting others, although they can still fall on a surface and contaminate a surface that could then be touched by someone, and that person then become infected by touching their eyes, their nose, or their mouth. We know that symptoms develop and in many people, not in all people, but in many people. And we know that 1 to 2 days before those symptoms develop, about 6% of cases have been infected in that manner. So people who are asymptomatic, but 1 or 2 days before they develop signs and symptoms, can transmit the infection to others. We also know that asymptomatic people shed virus, but we don't know whether asymptomatic people who never develop signs and symptoms can transmit the virus to humans. We don't understand yet whether that's possible. But we also don't understand the ease at which this virus transmits. And we'll talk about that more later. We could determine that by looking to see how many people have been infected in communities since the virus was first identified. But in places like China and in places in Europe and North America, it's very difficult because we don't have a test that can reliably tell us how many people have been infected in the past. So there you can see from known to unknown about transmission. And we'll go to the next slide. And this slide talks about infection. We know that all people are susceptible to infection, but we also know that those elderly people and people who have comorbidities, hypertension, diabetes, lung disease, other diseases, are at greatest risk of serious illness and death. We also know that these are the people who are extreme cases. Many people, 80% at least, have a mild illness that never comes to the attention of the health system. But those people who then become very sick with a cough, with a fever, do become available to the health system to test, and then some of them are isolated and admitted. Some are sent home to isolate in the home and to come back to the hospital if they're sick. And we don't yet understand mortality, but we do understand that in countries where there is a lack of hospital space and a lack of ventilation possibilities, including just forced oxygen, people have a higher mortality if they're elderly and if they're admitted to a hospital with problems with respiration, acute respiratory distress syndrome. We believe, though, that it's wise to try to keep people off ventilators if possible, and to try to get them to be able to oxygenate with some type of forced oxygenation that doesn't include ventilation in a hospital if possible, because 50% of those on ventilation will not recover. As I said earlier, we know the health system's ability to provide patient support influences their mortality. We don't yet know the long-term effects from infection after recovery, but in SARS, there have been many people who have long-term lung disease, scarring in their lungs, which decreases their respiratory capacity and which cause long-term effects. So we don't yet know what those long-term effects might be after recovery in this coronavirus. We know that outbreak containment is effective. As you know, in influenza, it's really not possible to identify clusters of influenza and then contain that outbreak and interrupt that local transmission. With this disease, with this infection, if you diagnose patients and isolate them using a PCR or an antigen detecting ELISA, if you do contact tracing and you put contacts under surveillance so that if they become ill, they're immediately tested, and if they're positive for coronavirus, they're isolated in a hospital or in the home. If you have a surge capacity for hospitals to make sure that people can be accommodated, and if you have the proper protective equipment in those health facilities, you can contain the outbreak and the pandemic in your country or in your geographic region. What's most important, though, is for people in the whole country, in the whole world, to understand that they have the power to contain this outbreak if they understand how to protect themselves and how to protect others. And this is where the message becomes very confusing for many people and for many policymakers and some health workers. There are three uses of masks. Masks are indispensable in hospital workers dealing with patients with COVID-19, and the N95 mask is the best mask to use, but it must be used with eye protection because you all know that eyes are also an entry point for infection. So in hospitals, masks, protective wear over the eyes, and other personal protective equipment, including gloves, are extremely important and necessary, and they must be put on and removed properly. For people who are sick and who are coughing or sneezing, but isolated in their homes, they should wear a mask to protect others, because that mask will protect them, others, by catching the droplets which are occurring when people speak, sneeze, or cough if they're infected. Now, the message becomes a little bit more complicated for people who are working in homes such as elderly care homes. If they're not able to physically distance from the people that they're taking care of, then they should be wearing a mask, not to protect themselves, but to protect those people from their speaking, coughing, or sneezing, should they be coughing or sneezing occasionally. So workers in healthcare, in elderly care facilities, should first of all be screened to make sure that they're not infected. And then when they work with these people, they should be wearing a mask if they cannot physically distance from those people. It gets more complicated when you're talking about the general public. A mask has no role in protecting individuals from infection. It cannot be effective for several reasons. Number one, it's been shown not to be effective in influenza. Number two, when masks are removed, if the outer surface is contaminated, then people who are removing them contaminate their hands, and then they can contaminate themselves. So the first two reasons, masks do not protect physically from infection. And second, they cannot be used effectively many times because people contaminate themselves taking them off. The third reason they aren't protection in communities is because if you're wearing them to protect yourself, you also have to protect your eyes, and that's really not quite feasible. So the reason masks can be worn in public is when people have to are trying to protect others from infection that they may have that they could transmit to others. And so some countries are recommending that everyone in public put some kind of protection in front of their nose and mouth so that they don't cough or sneeze or spit on others when they're talking. Some other countries are recommending them only when people go into places where they cannot physically distance, such as a crowded underground train, for example. But everybody must be wearing that mask. Everybody must be wearing it properly over their nose, mouth, and covering their chin. And if they don't wear them properly, they could be coughing, sneezing, and infecting surfaces, contaminating surfaces that other people touch and then infect themselves by touching themselves. So hand washing and physical distancing are the most important measures for personal protection. Masks have no role, and they only have a role in protecting others. So we know a lot. We know how to contain outbreaks and how to have an impact on pandemics, but the most important is for people to understand how they can participate in this. Some countries have introduced temperature checking on the forehead before people go into a public space, and then they put a sticker on their shirt or their blouse that says, "We have had our temperature checked and it's properly." This is not effective in stopping the pandemic, but it is a confidence-building measure. It continuously reminds people that there's something they should be worried about. So some countries, especially in Asia, have chosen to use this as a means of reminding people that they could be infected. Now, the immunity from this virus is really not understood. We know that B cells do produce antibody to covirus 2, and those antibodies are represented here in blue. Other coronaviruses also produce antibody, and so the yellow is coronavirus to one of the common coronaviruses that are endemic in humans. The antibodies must fix on the virus, and by doing so, they neutralize that virus. So we know that there is serum antibody produced by COVID-2. We know that there is serological testing with neutralization testing being done in many countries. Evidence from China shows that serological testing and neutralization shows that between 1% and 5% of people in communities where there have been outbreaks of coronavirus are seropositive, have antibody. And this is the same thing that's been happening in Europe. 1% to 5% of people tested in communities look like they've been exposed to coronavirus and are immune by or have antibody by neutralization testing, which is testing done in the laboratory that proves that antibody can allow covirus 2. That's not very practical testing, it's very costly, but it has shown that antibodies are present for COVID-2 in the blood. Animal models are getting more information, especially studies in the macaque. But all this shows that we really don't yet understand antibodies. We don't even understand if they protect against another infection. We know that for the common coronaviruses, protection is not long-lasting. There are antibodies developed, and those antibodies are protective for a time, up to a year maybe, but then people can be reinfected with that same coronavirus. We don't know anything about the immunity of coronavirus 2, and that's why the vaccine research is so important. It can maybe help us understand a bit more. There's one more problem in serological testing, and that's what we would all like to be doing, to be able to see if we've been infected, to have a home test that we could take, like a pregnancy test that would tell us we have antibody, we're immune, or we have a recent infection, we have IgM antibody, but that's not possible yet. There are many tests on the market, but none of them have yet been validated to show that they're highly sensitive and highly specific. In fact, we have reason to believe that even classical serological testing does not detect all persons who have been infected. The Chinese have been infecting people who have been testing people who have been mildly ill, had mild symptoms and signs, and they are not able to detect antibody in these persons. So though we know a lot about the virus and a lot about the epidemic and the pandemic, we don't know a lot about immunity. And so it's a real problem, and people are beginning to learn more, and anything that Spain has understood must be shared with the international community so that we can work together rapidly on this. Many countries are beginning to talk about transition measures, unlocking what's been done. And unlocking can only be done if there's risk assessment, understanding where geographically and where socially and where in industry and in small businesses there's a lower risk of infection. That can be determined by serological surveys, but we don't have a test that can really help us understand that at present. So it's very difficult to decide where and when to start when transitioning occurs, but there are certain things that must be in place. There must be a monitoring system that can provide vigilance as to what might be happening after unlocking occurs. Spain has an influenza-like illness system of surveillance for influenza that could be used if it's linked with a PCR test to determine whether or not COVID is occurring in people who have these symptoms. So monitoring is essential before transition begins. There must be a response mechanism that includes case tracing, contact tracing, isolation and contact tracing, and then isolation of people who become sick so that you can decrease transmission and keep it lower. Asian countries, by using this technique and other techniques, including some lockdowns, have been able to keep the reproductive number, that is the number of people infected from one person, below 1. And that's what we're all trying to do. So that requires a close response system. There also needs to be some technologies which are available today which might be useful. For example, there are apps which can be used that can be volunteer by people, and people can agree that if they're positive for COVID, their results go into this app, and people who have been nearby them who are in this app could be notified that they've been in contact and go get testing or isolation. At the same time, they could be used for contact tracing. When people are self-isolated after their contacts, they could use an app to report every day whether or not they have signs and symptoms. So we need to be thinking about new technologies. People have also been talking about immune passports. If I have an antibody, I can have a certificate which says I'm safe and can go back to work. Well, I think you understand from our previous discussion that we don't understand immunity, and it would be really wrong to give an immune passport to somebody saying you're protected, because we just don't understand much about protection. But certainly people with antibody would be less likely to get reinfected initially than people who haven't. But the most important population in a transition to make sure that the elderly in homes who have many, many different comorbidities could be protected. And that needs to be very, very important. So anyway, let me move on to the last few slides. Now I'm not able to do that for some reason. I think now, yeah, there, okay. The last slide shows you what most countries in Europe have been trying to do. They've been trying to get the massive number of infections that have required hospital care to a flattened curve. And so what we want to see is that peak flattening. And we're beginning to see that in Spain. You're beginning to see that in Spain. And that's a very good sign that there is, the lockdown has been having an effect. Now the country must use all these different methodologies that are available to decide on a best unlocking strategy, and then they must unlock. And what would happen would be, there will be an unlocking transition, and hopefully through continued monitoring and risk assessment, the outbreak may wane and waver, but it will continue at that lower level. And that's what needs to be done. And if it isn't, then there has to be an immediate response with a response team. So what I've done is tried to show you in the previous minutes, I don't know how many minutes that's been, and maybe close to a half an hour, what my understanding and what current understanding is about the current pandemic. And so I'd like to turn it now back to the moderator, and I'm happy to answer any questions that might be important to you in particular. So back to the monitor for further questions.
Thank you, Professor Heymann. This is Angeliki. Thank you. It was really, we always learn from you, even at this pandemic. Thank you for the presentation. It was succinct and everything clear. Yes, we are on the 26 minutes, Professor, so we are good. So now I will open the floor to questions from the participants in terms if there was a question that was relevant to the presentation or another question that you want to address to the professor. I wanted to remind everyone that this webinar is recorded and it's going to be uploaded on the MediPIET website. So for those of you who are willing for your voice to be recorded, please raise your hand and I will give you the floor so you address the question directly to the professor. Otherwise, we're going to address some of the questions that were written in the chat. So, let me see if there is any hand raised. No. So, but you can.
I have a question.
Yes. Who is speaking, please?
Anne-Sophie Le Carré from the Joint Research Center.
Hello, Anne-Sophie. Yes, go ahead, please.
Yeah. Thank you for the nice presentation, Dr. Heymann. My question was about the detection of infected people. You spoke about the use of antigenic tests with ELISA. How sensitive are those tests? You know, it's about testing the nasal swab. We're using antibody reconnaissance. How is it working?
It's not working it's not as sensitive as the PCR, and countries that are trying to use this are using this as an early screening test, but they're also comparing it to the PCR results. So the only standard recommendation is the PCR, as you know, and that's what should be continued to be used.
Okay, thank you.
Yes.
Thank you, Professor. Let me see if there's no. So if there is no other question that can be directly addressed to the professor, we will start addressing the questions that are on the chat in the chat.
I have one question, if I may.
Yes, speaking, please.
Alicia Padrón from the Instituto de Salud Carlos III from Spain.
Hi, Alicia. Yes, please.
Hello, hello. Thank you very much for this webinar. It has been really interesting. You have covered almost all the topics, but you have just be very concrete in one that it's increasing to have a very interest now. It's about the sequels that you have talked about. That there's no much know about it, but there have been described sequels on the lung fibrosis, but another one's also in the central nervous system. So do we have any more information from past coronavirus about the possibility of sequels and if they are long-lasting?
You know, there isn't a lot of information available yet. And, you know, what will be important is for countries like Spain, which have quite a large cohort of people who have now recovered, to follow up this cohort over time. And whereas I can't give you the answers, I believe you'll be able to give those answers to the rest of the world as time goes on. So I would just encourage Spain to continue with and I know it's been excellent work because I've talked with Bruce Edward from WHO who's been there, that you continue to follow cohorts who have recovered to understand what really are the long-term sequelae. I know in Korea, in South Korea, for example, there are cohorts of people who have been followed, and among them, about 51 have become PCR positive 2 or 3 weeks after having become PCR negative. And so the question is this PCR fragments which remain in those people and they're no longer infected? Is it a recrudescence of infection in people who became well but didn't completely suppress infection? Or is it new infection? And they're trying to determine that by looking for virus and comparing it genetically to the initial virus that infected. So Spain can be a major source of information for the world if you continue in your excellent science to be able to identify what's going on in the long term.
Thank you very much.
Thank you, Professor. So now, if there is no other question that can be directly addressed to the professor, I will give the floor.
I do have a question, may I?
Yes, of course. Sorry, because apparently there is no hand raised, so I couldn't say yes. Your name, please.
My name is Katharina Alpers. I'm the director of the German FETP, and I want to thank you very much for being invited to listen to that presentation as well. A great opportunity. And I would really like to know more about the role of children in transmission. What is known about that? And because in the discussions on the reopening for transition, the children play an important role when to reopen schools and playgrounds. What's the role of playgrounds?
Yeah, it's a very good question, and I have to say Germany also has done an extremely good job in containment of this outbreak and also is contributing much understanding. And hopefully, between Spain, Italy, and other countries, you can begin to answer that question which you just asked, which I can't answer, and that is the role of children. In China, it appears that there haven't been many children infected. In Singapore, the feeling was that children were not being infected either from evidence that kids had, because in their contact tracing, they were not finding children as a source of infection to adults or to others. But even so, they've recently closed their school system just as a precaution because they've seen an increase in cases, not in school children, but elsewhere. And for some reason, the political decision was to close the schools. I think that we can't really answer that question as well as we could answer for influenza. We know that children are at great risk of influenza because they have no immunity yet from influenza, and so they do take it home to their households. We know in COVID-19 that everybody is susceptible. And so is this virus selectively picking out others rather than children? It seems strange that it would be, but that's some of the initial evidence has suggested that. But nobody can say for sure. So I think the lessons that we'll learn from Denmark, which is opening its schools, from Switzerland, from Austria, which are planning to do that, and also lessons that we're learning from other parts of the world will be helpful. And one of the things that's very helpful is not to think of just unlocking a school. Maybe you want to unlock only parts of that school. So playgrounds would not be unlocked, whereas classrooms with adequate physical distancing between students and good hygiene, washing down surfaces, children washing their hands, may be the part of the school that would be open first. So it's not an easy, we'll open the school tomorrow. It's we'll open this part of the school tomorrow, and possibly it will even be in which geographic area that would be opened. I don't know if that's helpful or not, but that's the view at present. Over.
Thank you, Professor.
I got a question, if possible.
Yes, please. I think there is the question that is lined up is to Anna Belen. Anna Belen. So if you can unmute, you can direct your question, and then we will go follow the order of questions. So Anna, can you address your question?
Can you hear me?
Yes, we can hear you.
It's by mistake, so I just give the turn to the next person.
Okay, thank you. So who was the one who want to ask a question, please do so.
Yeah, sorry, that was me. Max Nerlander here, emergency physician in Sweden. So thank you for an excellent presentation here, very interesting. I wonder, so young people with no underlying conditions, who develop severe disease is a rare event, but it does happen, right? So I just wonder, so far, what is the understanding of that phenomenon? As far as
I can't understand that. I talk often with Johan Giesecke, who's one of your advisors there, and he's on our advisory group. And we haven't yet seen the breakdown of positive testing and hospitalizations in countries like Sweden. But Sweden is really a very important country in all of this pandemic because you followed a pathway of trying to prevent the elderly from getting infected, and while at the same time allowing more responsibility in the population to do the physical distancing and the social distancing and hand washing that is required. And I think it's a very sensible strategy. I think the UK had begun on that strategy and then backed down on that, and Sweden continued with it. And I think, again, the information that comes out of Sweden will be very important. And maybe you can already tell us something about what you know about infection in children.
Unfortunately, I don't really deal with children in the emergency room, so I don't really have great understanding of that thus far. But yeah, we do. Somebody said that basically because nobody really knows what the correct strategy is. It's very much the control group to really only history will tell how, what's the right strategy here.
That's right. Yeah, that's right. And normally you would be able to do a serological survey, and you'd be able to say, well, the people with antibody are this group, and therefore they're at greater risk. Unfortunately, that antibody test is still elusive to us. And as the Chinese have shown, mild infection, likely asymptomatic people don't develop detectable antibody by our current serological testing. So that's the major Achilles heel, if you would, the major problem in trying to better understand this epidemic and this pandemic.
Yeah.
Thank you. I think next in line in terms of question is Engela. Engela, can you address your question? Engela is from the Republic of North Macedonia. It's one of our MediPIET fellows.
Thank you, Angeliki. Hello, Professor. Thank you for your presentation. I have two questions, if I may, that are connected to one another. So in order to know if the disease is over, we actually test the positive patients twice after 14 days, and some of them may still come up as positive. Do we know for sure, for as long as they are positive on PCR, are they still contagious during this phase?
I answer is no one knows, and that's a real problem because in certain places they've had people who are PCR positive up until 21 and even more days. And the problem is, what are you detecting? Are you detecting live virus? Are you detecting PCR fragments? It's very difficult to understand and to interpret this test. And so the studies are going on in many countries looking to see if it's possible to isolate virus and, daily virus isolation attempts to really understand this epidemiology. But remember, this is only a 3-month-old infection or 4 months. We don't know a lot about this yet. And anything that any of you can do in field epidemiology training or anything else is really adding to the understanding of this virus.
Thank you. To connect to that, I want to ask for some specific case that we had. We had a positive case, and when we were tracing the contact, we found a patient, actually a contact, who had all the symptoms. And we tested her a few days later, and she came up negative. So what do we do in this kind of case? Do we test again? Do we set her free after the 14-day isolation? Do we keep her still on?
Yeah, as an epidemiologist, I would not set that person free. And I think you wouldn't either. And that's a real problem because that person will say, I'm not infected. And you will say, yes, but we want to isolate you. So I think you would need to do further testing, but until that test is clear in your mind that it's negative, that person should self-isolate, remembering that it's very possible that it's some other respiratory infection. So that would be my approach as an epidemiologist, but not as a human rights advocate, which would be something possibly different. So I think field epidemiologists have to make those decisions based on their common understanding and common sense.
I see. Thank you very much.
Thank you, Gail, and thank you, Professor. There is another question from Anne-Sophie. So, Anne-Sophie, please, you can address your questions, and then we are going to address some of the questions in the chat. Thank you.
Sorry, my hand was still hand. It's not a question. I forgot to take it out. Sorry.
Okay. Thank you, Anne-Sophie. Then I will give the floor to Iro now that has gathered the questions on the chat room by order. So, Iro, you can address the first question to the professor.
Thank you, Angeliki. Professor HEYMANN, we had a comment regarding masks and the question. So one comment was that in Kenya it is mandatory to wear a mask in public. And there is a question regarding healthcare staff and the N95 masks. So what is when there are no N95 masks available for doctors and nurses dealing with patients having COVID? Is it face shields or using 2 facial masks as only those are available? What are your thoughts on this?
Well, I think, I don't know what the policy is in Spain, but I would think the double masking would be a very clear one way of addressing this problem. But, I don't know what the policy is in Spain. I think if Spain is making mandatory wearing of masks when people are outside, the consideration should be, can people make their own masks? There are plenty there's plenty of information on the web about how to make those masks. And people understanding that an N95 filter on the mask that they're wearing is having no benefit because they're wearing that mask to protect others. And I think that Spain must have done a risk assessment based on the possibility that 6% of transmission could be occurring from people who don't yet have symptoms. So, I think there are many ways that could be dealt with. I'm not a policymaker in Spain, and I wouldn't attempt to evaluate what their policy is because I don't know what they've been, how their risk assessment has been done. But there may be ways that the public can use other types of protection which would spare those masks for hospital workers.
Thank you. And regarding assessment, risk assessment and assessment, there is another question regarding the reproductive number. And is there any new relevant assessment regarding the reproductive number, since now we are aware of many asymptomatic cases?
Sorry, because there are many asymptomatic cases?
Yes.
Yeah.
Is there any new assessment regarding the reproductive number for COVID?
Well, the modelers are continuing to do risk assessment, to do modeling rather, based on what they understand. And you know, it's a real problem because we just don't understand the numbers of people who are being infected. The maximum that we know about using neutralizing antibody is in Germany, where a community has reported 14% seroprevalence by using neutralizing antibody studies. That's the highest. Most countries and most cities, including cities that have been highly infected, are reporting 1 to 2 to 3%. So, you know, we don't have all the data necessary yet to understand what the reproductive number really is. And of course, it varies from location to location. Sorry.
Another question is the measures taken, the reaction measures during the transition period, and it's about any defined threshold transition period when you suggest to react with different measures.
I didn't get that. You were breaking.
I'm sorry. The question is if there is any defined threshold during the transition period where in order to react with different public health measures.
Is there a specific, you mean, is there a place to go to find information?
No, if there is any threshold regarding the outbreak and the numbers where we can suggest specific measures.
Well, I think each country has its own target of when they want to institute unlocking and other things. I think what's important to remember is that what's reported as infections in countries is just a reflection of how much testing they're doing. You know, everybody isn't being tested, yet people say, oh, Spain has 2 million infections, when I don't know how many you have, but they're just saying the number of infections that are occurring in Spain because that's the number of positive testing that's been reported. So there's great confusion, and I think countries in Europe have targets of flattening the curve of people going to hospitals, and when that target is met, they will begin to unlock. That's what I understand. Does that answer your question? You're having an echo where you're speaking. I don't know if there's a way of getting rid of that or not. Over.
I am not very sure too. Thank you very much, Professor. Just to let you know that our audience is from many different countries in the world, so your answers don't need to necessarily be targeted to Spain.
Okay.
Another question is regarding reinfections. So, do we have any evidence that there are reinfections? Have these been corroborated? And do we have evidence that COVID has mutated into different strands?
Okay, the virus is regularly mutating, and there's a database, GISAID, which has sequences for well over 3,000 viruses. The virus mutates. It's an RNA virus. It's not as stable as a DNA virus would be, and it does mutate. But there's not been any correlation yet of any mutation with increased virulence or transmissibility or decreased virulence and transmissibility. So the answer is that yes, mutation is occurring. No, there is no evidence that mutation is causing any difference in the way that this virus either transmits or causes illness.
Thank you. Another question coming from our participants is regarding the case definition and the people who show only gastrointestinal symptoms. So should these patients with only gastrointestinal symptoms be included in definition?
You know, that's a big question because there is virus found in feces, in stool specimens of humans. But that virus has never been shown to be live virus, and there's still work going on, and I hope Spain and other countries are contributing to that work to try to identify virus or to try to isolate living virus or infective virus from feces, because it's not yet been identified. However, in SARS coronavirus 1, the outbreaks in Asia, in Hong Kong, there was clear evidence that fecal transmission did occur in certain instances. But there's no understanding yet, and that's why it's important for everyone to be continuing in research areas that could identify whether or not there is living virus in feces.
Thank you, Professor. Another question is about the younger age group, the 17-23 age group. Is there any study on these younger people on how to explain the lower amount of infection?
It's not yet been explained, but I imagine, in my own view, they will probably fit in with the group of people who do not have comorbidities. And so even an 80-year-old who's in good health may not have serious illness, but if that elderly person has diabetes or hypertension or cardiac disease or lung disease, or has been a smoker, a heavy smoker in the past, these may be risk factors that cause severe illness. So I can't answer that. In the long term, I think there will be an understanding, and it may just be that younger people have stronger immune systems and, in addition, don't have the comorbidities. Because young people who are heavily overweight, who are quite obese, have a great risk of having severe disease, as do heavy smokers, according to the Chinese data. So we're beginning to understand, but it's early, and we can't expect that all answers are present now, but that all of you can be very big help in better understanding as we go on.
Thank you. And one more question that we have from the chat is, if a new wave comes in autumn or winter, what are your thoughts about the complexity of dealing with seasonal influenza and COVID-19 surveillance?
It will be a very big challenge. In fact, we had to deal with it in January and February in many countries in the past. And it won't just be for influenza, it will be any common cold that causes a dry cough and fever. And so it will be a big challenge. And, you know, it's something that we need to be planning for, even though we don't know how long this virus will remain transmissible within human populations. As I said earlier, it may become endemic, it may disappear, we just don't know. And so we have to be very careful and prepare well so that our influenza-like surveillance system is able to determine between persons with COVID-19 and persons with influenza. Hopefully by then, there will be rapid tests that can be used and rapid and inexpensive tests to determine this. But it will be a big challenge if this virus does indeed continue to transmit in the next influenza season in the Northern Hemisphere. We're getting a view of that in Australia in the Southern Hemisphere when winter is coming up, and in South Africa and other places, and we'll have some lessons learned from those places as well.
And a last question we have is, what are your thoughts? What do you think about the quick test?
Well, the rapid tests are not yet validated. And so I would say nobody should be using any rapid tests except for the PCR rapid tests, which are being validated now. But any test to do with serology that's a rapid test has not yet been validated, and we need to wait a few more weeks until validation is done, because there are many countries doing this to try to compare the sensitivity and specificity of the various tests. So that's not yet done.
Thank you. And another one. Are there any special criteria for reopening the countries after lockdown?
These criteria will be decided by the countries themselves. I anticipate that it will be when their target has been reached. Whatever the target was for lockdown, once they've reached that target, I would think they will begin to think about unlocking. Some countries have already begun, as you know, Denmark, Austria, Switzerland. Sweden has never really locked down, although they're beginning to unlock some of the schools, I think, which were locked down. So we'll have lots to compare and lots to observe as people begin to unlock, and that'll help countries that haven't yet unlocked understand the issues. I'm going to have to leave the webinar now because I have another engagement in 5 minutes. So if there's one last question, I'd be happy to answer.
No, Professor, thank you very much, and thank you for the extra time that you gave it to us. It was a complete honor to have you with us and share your great expertise, and we are very honored. As Zero said, the participants are from all over the Mediterranean region and other European institutions and non-European institutions. So we thank you very much. We will, of course, free you now. Thank you, and we will follow up, of course, over email. Thank you so much.
Thank you very much. Bye-bye.
Bye. Okay, so I would like to say bye to everyone. Thank you all for your participation. As I told you, the webinar has been recorded and it's going to be uploaded on the COVID dedicated spaces website.
Yes. Sorry.
Yes. Yes, sorry. Yes, Isabel. Yes, sorry, Isabel. Yes, I'm sorry we wouldn't see you there. So I will leave the closure of the webinar to Isabel. Thank you, Isabel.
Thank you very much, Angelique. I would like to take only 1 minute to close this webinar. I really thank you, Dr. HEYMANN, for this excellent presentation and for your kind disposal to sharing this time with the MediPIET family, fellow supervisors, senior professionals, etc. Your contribution has been excellent for the scientific point of view. Can you hear me?
Yes, Isabel, we can hear you.
Okay. I said that your contribution has been excellent for not only for the scientific point of view, that I would like to stress your contribution in terms of your accumulated experience on global health, gathering, terrain, country experience, United Nations institution, and academic position. Now, to finish, I would like to thank you on behalf of the counterpart involved in MediPIET, the Institute of Health Carlos III, leading MediPIET with the support of the Foundation of Health, Childhood and Social Welfare, and the scientific leadership of ECDC, national public health institutions also participating in France and Greece. This project is published by the European Commission, DG DEFCO, under the CBRN initiative within the Instrument for Instability. Thank you, Dr. HEYMANN. We hope to be able to count on you in future MediPIET events or new forums to discuss regional global challenges in the future. Thank you very much for this presentation. We count on you.
Yes, thank you, Isabel. We would like to thank everyone who's leaving now little by little. So thank you all, and we will be in touch for the next webinar. Thank you, everybody.